Good evening. It doesn't look like evening, but that's what daylight savings will do to you. Welcome to the third lecture in this year's series of Voices from the Vanguard. As you know, this is a joint effort between the Center for Tropical and Emerging Global Diseases and Pat Thomas, the Knight Medical Journalism Professor here in the Grady College of Journalism and Mass Communication. It's really good to see you here today. I know that frisbees call out on the lawn, but I appreciate you showing up. Our speaker today is Dr. Julie Jacobson, who is making her second visit to the UGA campus in about 6 weeks, for which we are very grateful. The last time she was here, she helped in a meeting where we brought together about 35 people from around the world trying to come up with a unified protocol for some studies that we're going to be doing, and Dr. Jacobson was instrumental in that meeting. But today she's going to be sharing some things about global health in a broader spectrum. Now, before I ask Dr. Lee to introduce Julie, I would remind you that there is next door after this talk a reception in Demosthenian Hall. And I would remind you that we have one more in the lecture series, and that will be on April 13th. And that'll be Dr. Jenna Davis of Stanford University, and she's going to talk about water and sanitation and some of her efforts in the developing world in terms of trying to get clean water to people. So with that reminder, I look forward to tonight, and I'll ask Dr. Lee to come up.
Well, good evening, everybody, and thank you, Dan. It's my privilege tonight, hopefully without affecting the slideshow here, to introduce our speaker, Dr. Jacobson. As the slide says, Dr. Jacobson is a senior program officer with the infectious disease group, which is a section of the Gates Foundation's Global Health Program. Dr. Jacobson, and I hope I can call you Julie, oversees the grant programs designed to control or eliminate tropical neglected diseases, and she's also responsible for efforts to develop efficient delivery of new vaccines for infectious diseases. I think it would be very difficult to overestimate the impact that Dr. Jacobson and her colleagues at the Gates Foundation have on global health. Just simply consider the fact that the Gates Global Health Program invests $2 billion annually, an amount that is greater than the yearly budget of the WHO, which has 193 member countries. Through that unprecedented level of support, the Global Health Program of the Gates Foundation is able to support a variety of world-class programs, such as the Global Alliance for Vaccines and Immunizations, the Children's Vaccine Program, the Global Fund for AIDS, Tuberculosis, and Malaria, and the Grand Challenges in Global Health Initiative. And of course, it is also supporting the large-scale effort to reduce morbidity from schistosomiasis in several parts of the world that is being directed by our own Dan Colley, of whom we are enormously proud. But just as impressive as the magnitude in dollars and its own direct impact is the influence that the Gates Foundation is having on the generosity, the focus, and the fervor of other donors, not the least of which is the U.S. government. I think it's no exaggeration to say that the Gates programs have quite literally changed the face of global health efforts over the past decade, and we are all indebted to the work of the Gates Foundation, to Dr. Jacobson and her colleagues for making such a profound difference. Even a brief perusal of Julie's inspiring biography makes it abundantly clear how she rose to such a level of responsibility with the Gates Foundation. The basic facts are these. She obtained an undergraduate degree and also her medical degree from the University of South Florida. She obtained a diploma of tropical medicine and hygiene from the same Peruvian university where I once struggled to give a research lecture, and this tells me that her Spanish is way better than mine. She also completed residency in family medicine in Tallahassee, Florida. But these facts don't in themselves distinguish Julie from many others that have a similar background. Rather, it's clear from the very beginning that Julie had a great interest, was inspired by the health challenges that face so many of the world's population, and more importantly, was actually motivated to do something about that. As a medical student, she co-founded a program called Project World Health, and she spent time as a medical student or as a newly minted physician providing care to patients in parts of Africa, in India, and, oh yes, in poor and underserved portions of the United States. From 1998 to 2000, Dr. Jacobson served as an epidemic intelligence officer, I think a lieutenant something or other, a lieutenant colonel, in the U.S. Public Health Service Commission Corps, helping to evaluate health surveillance and assistance programs in various countries in Central and South America, including in response to natural disasters like hurricanes and earthquakes. From 2000 to 2007, she worked at the Seattle-based international nonprofit Program for Appropriate Technology in Health, otherwise known as PATH, where she rose from program officer to director of their multinational effort against Japanese encephalitis, managing a $35 million grant to control this disease in endemic countries. From 2006 to 2007, she served as scientific director of PATH's Immunization Solutions Program with responsibility for clinical research and clinical trials, including vaccine studies. Julie then joined the Gates Foundation in May of 2007. Her expertise has been widely recognized and sought after. She has chaired or been a member of a number of international working groups or standing committees, and in 2005 she received the Ian Hardy Memorial Award from the Centers for Disease Control and Prevention for outstanding contributions to vaccine-preventable diseases. She has co-authored a book chapter on vaccines and published a number of scholarly articles. As I said, Julie's biography is inspiring, and it could serve as a roadmap for students here and elsewhere who want to make their life's work about alleviating the suffering of millions of people around the world. It's an honor to have her visit the campus, and I am honored to introduce her. Please join me in giving a very warm welcome to Dr. Jacobson.
Wow, that was quite an introduction. Made me tired, actually, thinking about all of that. I'm really happy to be here today, very excited to talk to you and share some of my experience. And I look forward to if any of you can come to the reception afterwards. If there's questions or things you'd like to talk about further, that's part of the reason why I come to these. So please feel free to ask me questions after the talk or then. So just a basic outline of the things that I thought I'd talk about today. One is I wanted to define some of the pieces of what it takes to create change, because I think that that's what we're all looking for. I think that that's what we're trying. That's why we're here, and getting an education is to try and create change in the world in one way or another. For that, I'm going to tell you a little bit about my journey and some of my stories through this. One is with Japanese encephalitis, a little-known disease, and the other is with the neglected tropical diseases in which I work now. And then I'll go back and kind of review some of those pieces. So you've heard a bit of my bio now. So I'm a family practice doctor, and that's usually what I always come back to is I'm a family practice doctor. I think about people, and I think about what it's going to take to make them better within the unit of their family. And I think that global public health is the same thing. Countries, individuals, communities are all that same way. You have to think of them holistically. So I always come back to that piece of the basics of primary care. The CDC, I was in the EIS. At PATH, I was with the Children's Vaccine Program, and now with the Bill Melinda Gates Foundation. So I have something to tell you about each one of these experiences of going through these. And my first one is with getting my medical degree and going through my family practice residency. And the first thing is that, I knew that I wanted to do international public health from the time that I started medical school. It's kind of how I went into all of these different pieces. And there really was no education for doing international public health. And so I kind of had to create it as I went along. And so I started this international awareness group. We collected medical supplies from hospitals. I did bagel sales. I started recycling so that we could use the recycling money to start to get enough that we could send people out to different international exchange programs. We started an international exchange program with students from Colombia, South America. And then when I went to my family practice residency, helped them start an international health track working in Ecuador and in El Salvador. And none of these things existed before. And so one of the really important things, I think, as you go into your education and you're thinking about your life is the path that you may want to lead may not be laid out there for you. You have to make it yourself. And take advantage of every opportunity you have for an elective and make sure it's something that's building towards what you want it to be. So in my CDC time at the Epidemic Intelligence Service, I had an opportunity. I had worked in a refugee camp in Africa after graduating from medical school. It was quite an intense and overwhelming experience. I had 200,000 people I was put in charge of 3 months out of medical school. And one of the things I noted during that time was that part of the problem was that we didn't know what we were doing, and that people were reacting and not really doing anything based off of any information. And I said, we've got to be able to do this better. So I decided I was going to go to the EIS, and I wanted to work in refugee health. And when I got there, there was no position in refugee health, and I had to go work in natural disasters, which I was extremely disappointed about. But actually, it was exactly what I needed. In natural disasters, everybody wants things to get better. And you had the opportunity to come into some place where everything had been taken out and start all over again. You do a rapid needs assessment, set up an international program, set up a way to monitor it, and then use the data you collect from that to do global development work. And so through that experience, I got an incredibly vast amount of experience from neglected diseases, vaccine-preventable diseases, diarrhea, water and sanitation, food security, which I would have never gotten otherwise. So seizing the opportunity that when they're placed in front of you to get as much as you can out of them. So at PATH, the Children's Vaccine Program, the key is to see the need and embrace it. And I'm going to talk a bit about my experience at PATH and getting into the Japanese encephalitis experience. So my job at PATH. So I started out going into this job at PATH. My husband got into school in Washington State, and so I wanted to live in the same city. I thought that would be nice. And so I had to move from the CDC, where I was very happy, to go to Seattle. And so there was this nonprofit PATH, and I was like, okay, so they're doing some vaccine work. I'm like, vaccines, well, it's not really that interesting, but okay, I'll at least stay 1 year, and I'll give my best during that time. So here were my responsibilities: working on strengthening routine immunizations, preparing for rotavirus vaccine introduction, strengthening yellow fever immunization programs, preparing for Hib vaccine introduction, and supporting the development of Gavi, which is Global Alliance for Vaccines and Immunization, country support, and application processes. So this was the first big grant in health that the Gates Foundation had ever given. It was $100 million of unrestricted funds. And let me tell you, this was one of the best jobs I've ever had. It was so much fun because you could really solve problems and do things to create change. So in addition to these, I had this other thing. Oh yes, there's this problem with Japanese encephalitis in India. Why don't you go to India and just make some recommendations, I'm like, well, I don't really know anything about Japanese encephalitis, I've had my clinical tropical medicine training, and there's 2 paragraphs in there on that, so, I thought that was pretty helpful. But they said, there aren't a lot of people who know a lot about Japanese encephalitis, so I got a team and we went down. So I did my research. So I figured I better learn something. It's an arbovirus in the Flaviviridae family. Mosquitoes are the vector. It's transmitted by mosquitoes. Pigs are the amplifying host. So the mosquito bites a pig, bites a person, and the person gets sick. It's frequently got a seasonal distribution. I have the picture of the virus, E protein, M protein. Yeah, I remember those. Okay, so I'm feeling like I'm getting the gist of this. Okay, JE, seen in Asia, children less than 15, and there's a vaccine available. So with this, I go to India to make some recommendations. And what do I see? I stepped into the middle of an outbreak of Japanese encephalitis. And I see these kids dying on the beds, knowing that there's a vaccine available. And I was shocked, absolutely appalled, couldn't believe that something like this happened, and that I have 2 paragraphs in my book, my Hunter book, which is very thick, on tropical diseases, on this disease that's affecting 3 billion people in Asia. So I saw the need, and I realized that somebody needed to do something. So I went back to my facts, seen in Asia, children less than 15, vaccine available. And then I realized, and I tried to get more information on what was really happening and why there hasn't been a lot done in this area. And one of my interesting observations within this space is that there's really only an investment into a lot of these diseases, particularly these tropical diseases, when the disease comes into a country with resources. So JE had gone into Australia. And so the only information that was really talking about the transition of this virus and how it moved around came from work, this is a slide from John McKenzie, when they tried to figure out how in the world they got this virus into Australia. So they traced the virus collecting mosquitoes from one part of Indonesia to the next, and they traced it going all the way across Indonesia, into Irian Jaya, into Papua New Guinea, down to the coast, and then there was a tropical storm which blew the mosquitoes over to Australia, and they got the virus down into Australia. And this was the most information available on the virus transmission, although 3 billion people in the world have been suffering from this disease. So I went back to the JE transmission cycle. Okay, so there's got to be a little bit more to it than this, right? So JE is transmitted between birds, migratory birds, and pigs. And so the challenge is that people get, when you get bitten by a mosquito and you get JE, you're not part of the transmission cycle. We're called a dead-end host because we never get enough virus in our blood that the mosquito can bite us and continue to transmit disease. So it's a zoonotic infection. It's generally in the animals and not in people. But actually, the transmission cycle is much more complex than that. And we only really know a lot more about this because West Nile, in the same family as JE, made it into the United States. And there is unbelievable amounts of information on West Nile. How many birds, what kind of virus levels each of the different birds get. So here we have the big problem, mosquito and biting a child. So we have cattle, and we know that the cattle are susceptible too. But the primary high levels of virus come from the pig. But the problem is the migratory birds, and that actually is in reptiles and snakes and in domestic fowl. So when we look at this and we look at what's the solution to solve this problem, this is not something we're going to remove from the environment. This is deeply embedded in the ecosystem. So and most of the approaches to JE had been focused on taking care of the virus or trying to remove the pigs from being around people. But this isn't going to work. It hasn't worked. It didn't work anywhere that they've tried it. The only place actually it did work was in Singapore, where they have no pigs in the entire city and the whole country is urbanized. But that's not really an option for India or Indonesia. So when we look at the different patterns of age distribution of cases, so yes, it's true that in a lot of places you see most of the cases under the age of 15, as you see here from a slide from Andhra Pradesh, where you get, by the age of 16, you almost see no cases that are reported. But actually, this isn't the whole case. And what you actually see is in some other places where the virus is newly coming into the population, you see a significant amount of disease burden that happens above the age of 15. So this is also places where the virus doesn't get recognized because it's not following that simple pattern of having pigs and of being under the age of 15. And the pig thing is a really important part to the global picture of Japanese encephalitis because Indonesia believed that they didn't have Japanese encephalitis because they're a Muslim country and they don't have pigs. And so therefore they couldn't possibly have this disease that's associated with pigs. Well, you remember my slide that showed you how the virus went all the way through Indonesia and into Australia. Nobody at that time said, wow, I wonder if Indonesian children are suffering from Japanese encephalitis. They only ever looked for it in mosquitoes. And actually, they have a huge issue with Japanese encephalitis in Indonesia, with a different seasonal pattern because of the way the mosquitoes come from rice paddies. And one rice paddy, this is a very fascinating fact, one rice paddy can produce 30 to 50,000 mosquitoes in one night. You wonder how they know that. Well, actually, I know how they know that. I worked with a Chinese colleague who actually had a graduate student go out and count mosquitoes as they came off of a hectare of land. But with numbers of mosquitoes like that, there's no way that vector control is going to work. It's just not even feasible to consider that. So the seasonality of Japanese encephalitis. In temperate climates, you have sporadic transmission, relatively low incidence, some seasonal epidemics. In subtropical, you get hyperendemic transmission, higher incidence rates with different. And tropical Asia, year-round transmission. I actually think that's too complicated. Basically, you have two patterns. You have seasonal epidemics where you know between this month and that month that you have something going on, which is the case in India. So even though they didn't know what they had, they called it brain fever, they knew something was going on because during these 2 months out of the year, their hospitals were filled with kids that were encephalitic. And so they knew that there was something special. In Indonesia, they have just a couple of kids every month year-round, so they never had anything drawing their attention to it to show them that they had a problem that needed to be solved. So in getting more in-depth into understanding JE, I learned that it's the leading cause of viral encephalitis in Asia. It's the leading neurological infection in Asia, viral infection in Asia, and 50,000 cases are reported annually, but there are not diagnostics available, and there's no reporting system, so we know that it's severely underreported. 10 to 15,000 deaths were reported annually, with a case fatality rate of 5 to 35. But when you actually start getting into countries that don't have a good access to care, the fatality rates can be up to 70%. And JE-related disabilities, in 30 to 75% of kids are left with a long-term or lifetime disability. So JE, prodromal stage, you start off with 2 to 3 days of fever, headache, then you go acutely encephalitic. There's a change of consciousness. The child goes into a coma or has a seizure, and in the rapid progressors, they die. Then you have a subacute stage, 7 to 10 days. Fever decreases, mild symptoms decrease, but you have risks of secondary infections because the kids are in a coma, they get bacterial infections, they get lung infections. And then you have a convalescent stage, 4 to 7 weeks. Mild cases may recover during this, others have slow improvement but have long-term disability. And actually this child was quite interesting in a hospital in India. The children get what's called a mask-like face, and it looks like she's looking at something, like she's reacting to something, but she has no connection to her environment whatsoever. She's completely dissociated from anything that's happening. So the disability piece. The disability is quite significant. You have fine motor movement that's affected in 72%, limb paralysis 44%, abnormal movements. I don't have to go through and list all of these, but one of the most remarkable pieces is the behavioral changes that happen. Kids have a remarkable behavioral component that happens after this, very aggressive, very emotionally labile, and frequently will not recognize their own family members, which is very, very disturbing to a family when a child comes in and asks, "Where's their sister?" and they're asking their sister. And this is a case that I saw in Indonesia, which thought that they didn't have any of these kind of cases. And I went to their hospital log and looked through their hospital log, and I said, "Do you have any encephalitis cases?" They said, "Oh, no, we don't have any of those." And I went into their ward, and I found 6 cases sitting there, right there at the time that I was in the hospital. This was one visit in one hospital in one place. And the interesting thing is that this comes into data and how you collect data. I asked them if they have Japanese encephalitis. They don't know what Japanese encephalitis is. I ask them about encephalitis, and they're not actually even quite confident with what I mean by that. And when you look at the hospital logs and you go through, most of these kids were either admitted with a seizure, a fever, or with nausea and vomiting. And then after they got into the hospital, they went into their coma. And so that they weren't recorded in the recording book as being encephalitic because they progressed to that, and their records didn't keep those pieces, so that they didn't have any record of these happening at all, and there was no way retrospectively to go back and find out about this data. So there's also intellectual disabilities that come from JE. Abnormal intellect is in 72% of kids, frank retardation in 22%, and a lot of other various neurological pieces. And this is one of the cases that I saw when I was in India. I went and I said, well, they wanted to show me a successful case, a case that had successfully overcome the disease. And I went to find this little girl in her village, and we got there, and they came out, and she was with her mother, and we started talking to them and finding out what was going on. And actually, this little girl couldn't find her own home. She had to have people bring her back to the house. But she could walk and talk. So they considered her normal and recovered, even though she didn't recognize her own family members. She couldn't find her own home, and she was completely non-functional and could no longer attend school. So when we're looking at how diseases are counted, it's innately linked into our ability to record that information and have it available. So I'm going to go into JE surveillance and control and say, now I'm going to dissect what were the problems, what was not working. So we start off with a person who's well and happy, and then they get an infection with the virus, either an asymptomatic infection, where they're infected with the virus but they don't get symptoms, or they become a symptomatic patient and they become a case. So what we need then is that we need to have syndromic detection. We need for them to recognize a compilation of symptoms, not necessarily know exactly what the causative agent is, but a syndromic detection of saying this is diarrhea, this is pneumonia, this is encephalitis. With that, you need to then have a sample that goes for a laboratory confirmation. You have case reporting, and that case then has to be reported into some sort of system. That data needs to be compiled and analyzed. Then the information from that system needs to feed back to a control program, so there's some action that happens from your surveillance data. And in this case, our options are human vaccination or vector control. So with JE, the challenges with this, and this is not unique to JE. This is basic public health and basic surveillance. All of these pieces, these two interventions may change, but everything else is basically exactly the same in any of these systems. Our problem is that we don't have syndromic detection, and people are not following what encephalitis cases are. Even if you have the syndrome, there's no laboratory tests that were available in the countries, and there's no commercialized laboratory test, so they were never being laboratory confirmed. So, which meant that there was no case reporting that was going on, no data analyzed, no feedback for a control program. And then even if we made it that far, the challenge is that what was happening is that information would go to a vector control unit, which took care of mosquitoes and not people, and there was never any communication between the immunization program here. So we have a division in which the way our systems work. And so our own public health system is divided into vector-controlled diseases and human diseases, and they don't talk to each other. And this was an incredible barrier to actually moving the program forward, was getting people to actually communicate across these. So there were a lot of things to fix. So the other piece to add on top of this is that there is no treatment for Japanese encephalitis. It's a viral infection that invades the brain. There's nothing you can do for it except supportive care. So there are things you can do that can affect outcome by making sure that the child's breathing, that their seizures are controlled, that you're taking care of cerebral edema, making sure that the child gets nutrition and fluids, and don't get secondary infections. But these are not treating the virus. They're just supporting the person so that they can survive the virus long enough to become well. So control programs, as I said, there was mosquito control here, and they used spraying and bed nets, neither of which worked, because what they would do is they'd wait until there was a case that was found, and then wait until there was a potential diagnosis, and then they'd go and spray the village where it was happening, and by the time they got there, the epidemic was over, and then it looked like they were successful, but then it would come back again next year, and so they were just constantly doing this and saying, oh, look, it worked, oh, it's back again. So it never actually had any impact on disease, because when you look at also how the infection goes, a person's bitten by a mosquito, they have to become infected, then be seen, and with JE, the diagnosis is difficult because it's based off of antibodies we find within the blood. And that takes 7 to 10 days to reliably come up. So from the time the child's in the hospital, 7 to 10 days, you're immediately, even with a really good system, 3 weeks away, 2 to 3 weeks away from the time in which the child was exposed. And you're way too late to start anything on the vector control, even if it was possible to get rid of those 30 to 50,000 mosquitoes from 1 hectare of land. Bed nets don't work at all because the mosquitoes bite in the early evening, and nobody is under bed nets during that time. And the mosquitoes bite outside and not inside, but they gave bed nets anyway. Pig control. The other thing is they tried segregating, slaughtering, and vaccination of pigs, none of which worked. It did cause a lot of trouble, though. In India, they were very famous. One state was having an outbreak, and so they chased all of the pigs with guns across the border to the other state and created this, oh my gosh, it was very funny, whole civil unrest about these pigs and trying to chase them back across the border. It was a mess. Which leaves us with vaccination. And when we look at the flaviviruses, this family of viruses, this is the same family that has yellow fever in it, and the only thing that's ever worked in the flavivirus family has been vaccination. And so when you have a disease that's in your ecosystem, you have an exposure that you can't control, your only hope of controlling that disease is to come to the individual level. And that's exactly what vaccines do. They protect at the individual level. So my question was, okay, what worked? Let's go back. Let's look at a country where this was actually successful. And Thailand actually has incredible data on this. So here we have, this is the years 1970, 1980, 1990, and 1997 here. And this is the number of JE cases over time. Between here, at this point and this point, what we have is we had vector control. So Thailand was using vector control. I thought, this is definitely what's going to help us. Let me see if I do my click, if that works. Oh, no, sorry. So they had vector control that they used between 1970 and 1980. They got to 1980, and you see the trend is not good. They said, this is not working. We are not solving this problem. We need to look at it again. So then they decided during 1980 and 1986 or 87, they went back and they decided what we're going to do is we're going to try and get cases early. We detect them early, we'll get in there, and we'll do very focused control measures as quickly as possible in the affected populations. And so that they had an emergency response team that went out and to try and work with this. And again, you see no impact whatsoever on the cases that they were having. So here they started doing some vaccine trials and some model vaccine introduction. And in 1986, 1987, they started EPI, the Expanded Program on Immunizations, introduction of JE vaccine sequentially into different provinces that were affected. And what we see is that as they added more provinces, the disease just falls away. And now they have maybe 5 cases that happen a year, mostly in populations that are coming across the border from other settings. All right, so now we're getting close to the answer. We have population at risk. What do we need to protect them? We need good surveillance, we need strong case management, and we need an immunization. So this brings us to the PATH project. So I was able to successfully get additional resources from the Gates Foundation, at that time requesting them, for a project to work specifically in this area. And with that, it was for increased data for decision-making, surveillance support, and helping get a diagnostic that was actually available and could be used within countries. Vaccine development, making an available, affordable, safe, and effective vaccine that was simple to use, and country support and advocacy, and planning and technical support. So within the vaccine development, I have a lot of things I want to tell you, so I'm going a little bit fast. Sorry about that. But within the vaccine development piece, there was a vaccine that was available, and it was based off of mouse brains. So what they would do to make this vaccine is they would take a baby mouse, and they would inject them with live virus, and then they would wait for the baby mouse to get sick. When the baby mouse got sick, they'd kill the mouse, take out the brain, grind it up, take the virus out, and put a little bit of formalin on it, and with that, you got 1 dose of vaccine. 1 baby mouse, 1 dose of vaccine, 3 billion people. It's not going to work. And the biggest challenge with this is that it was not scalable. Each one of those steps required a human being to do each one of those parts. This was not going to be the solution for Asia. And so that's why the vaccine mainly went to military and to tourists that went into different areas, but it wasn't available to a majority of the population. And it was very challenging to see what we would do at this point. So we went back into India, re-looked at what India had. So basically, India had data since 1953. They first knew that they had JE transmission. Their biggest outbreak was in 1973, which really started off a lot of this in West Bengal. The challenge was, as I said, the JE control program was under the National Vector-Borne Disease Control Program. And so their response, anytime there was a JE case, was to go and spray, go take care of the mosquitoes, which was ineffective. India had never introduced a new vaccine into their immunization system. So India has never introduced hepatitis B, never introduced Hib, never introduced They do not do measles campaigns. They don't do any of these things. They have a lot of people, and they've been they've been very slow to take on a lot of the new vaccines that have been done. So here I am coming in and suggesting that they're going to use a vaccine, and they've never introduced a new vaccine into their system before. The other challenge is that India uses vaccines that are made in India. So India has a very good vaccine production, and they want to use vaccines that they make in country, and there's no vaccine that's made in India. So no large-scale injectable vaccine campaign had ever been done in India. So India has done lots of experience when it comes to polio, which is drops that they give in trying to control polio, but they've never done any of the measles campaigns, so they've never done a large campaign with with syringes and needles. The domestic supply in India was limited to, they made a little bit of the mouse brain-derived vaccine in a facility, was about 200,000 doses. It requires 3 doses per child plus boosters that happen later, so you can tell that 200,000 doses is not going to be sufficient to cover India's population. And JE affected the areas in India that were in some of the hardest to reach areas. So UP, Uttar Pradesh, and Bihar, which are kind of globally famous for being extremely difficult places to work. Their routine immunization coverage rates in UP are 26%. And I think they've actually decreased to 23%. And so when you come in thinking that you're going to be able to solve a problem in a place like this that has been still the hotbed area of polio transmission, you're talking about some of the most difficult places to work. So what happened? So we started working in India. We started working in the state of Andhra Pradesh and started helping them with the laboratory, worked with them and told them, when I was told to come in and help with some advice, we told them what they already knew. They needed vaccine. And so the government within the state themselves started introducing the vaccine. So we had some experience in working with them, and they had some data now within India showing that vaccine did work. And with this, we started bringing together all of the affected states. So all of the affected states now knew that there was a vaccine and that they could do something about this, and the answer wasn't to spray for mosquitoes. So in 2005, there was a large outbreak in the state of UP in an area called Lucknow and Gorakhpur and the surrounding area. And it's actually a question in my mind whether this was a true outbreak or whether there just started to be actual reporting of cases. One of the other big challenges within India is that because there was no solution to JE, people who reported the disease lost their job or were shifted to work in some other place that they didn't want to work. There was huge disincentives within the systems to even report cases. And so one of the things is individuals are not going to look at a problem unless there's a way to solve it. And so when we come and we start talking to countries about these challenges, we have to be able to offer them something to solve the problem. Otherwise, they don't want to hear it. They have enough on their plate. So unless we can offer a solution. So in 2005, there was this big outbreak that got into the press. It was huge, lots of information going on, and then there was an outcry. So I don't know if you can see all this, but I'm summarizing what happened very quickly in a decision-making process that happened with India as this outbreak happened. So what happened is that the states, each of the individual affected states, started to demand vaccine. They knew that there was a vaccine. They knew there was something they could do about it. This outbreak was happening in UP. They wanted it in their state. They wanted to be able to do that. It also happened at the time of an election within the state of UP, which also was very good for the government to show that they could help solve this problem that had been a perpetual issue in the country and was well recognized amongst all of the people to be brain fever and this thing that left their kids debilitated. So there was a decision to act, and this is one of the key pieces, is that for us that are working with countries, have the privilege to go in and work with countries, when the decision to act is there, it's our job to make sure that we can do everything that will facilitate their ability to be successful with that. And so what happened is there was a review of data, which we had already compiled a lot of this, worked with them on this. There was a committee that was put together to review all of this information. We reviewed all the control measures, showed how every year the vector control information or the vector control approach had failed. We summarized the experience outside of the country and brought that in for the committee to look at, then began to look at product availability. And a whole other section of this project was working on getting an available vaccine. And the interesting thing is that China has had huge amount of Japanese encephalitis cases. And They had been using the mouse brain-derived vaccine. They also have a lot of people, and they realized, you know what, this mouse brain-derived vaccine has too many side effects, and there's no way we can make enough for people. So they did their own research and development, and they developed a live attenuated vaccine that worked and was incredibly effective with a single dose. And this was really one of the transformative technologies now, was that possible product, getting it into India. So with this, we looked at the product and availability and came up with a strategy of where the vaccine would be introduced and what population it would be used in. And then there was a decision which had the National Technical Advisory Group for Immunizations endorsement. It had input from the science. It had recommendations from the global level. And then from this point of the decision, this is great. The country's making this huge step. What do we need to do to make sure that they're actually successful in enacting this? The vaccine had to be licensed. There had to be planning for implementation. The vaccine had to be procured. And there was huge administrative processes. There had to be program monitoring and reviewing systems. And then they had to decide if they were going to continue the program. And so this happened in an incredibly short time frame because there was an outbreak and they wanted to vaccinate before the next JE season, which happens annually, as I had said. None of this is magic. It's actually, there's a lot of hard work, preparation, flexibility, and respect. So when you're working with a country to solve one of their problems, it's your job there to facilitate and empower them to be able to do that. And it's very challenging because a lot of decisions get made. You have to provide information and that will facilitate their pieces without telling them what to do, because frequently that results in exactly opposite of what you want to happen, and they decide they're not going to do it. And I think that this has been one of the challenges in some of the polio eradication efforts, is that it was a program that was imposed upon countries as opposed to something that was problem-solving issues that the countries saw for themselves using their own capacity to be able to solve the problem. So, summarizing a lot of things, the vaccine was introduced into India. So this was a historic event. The program was planned and the vaccine was licensed, which frequently takes over a year to get a vaccine licensed, in record time, 8 months. So they decided that they were going to introduce, we had vaccine licensed in the country and into children within 8 months. It was the first foreign vaccine introduced into the routine immunization system in India. It was the first new vaccine introduced by the government of India ever in their history. The first injectable vaccine campaign ever done, and everybody said, oh, India can't do this. They just can't do this. It's too much. All of those needles, and it's too many people, and how will we ever be able to do this? And we got coverage in the hardest to reach parts of India, 26%. And we got coverage rates of 95% in the same population, because this was a need that they knew that they had. They wanted to protect their children. They recognized it as an issue, and they were committed to it. There was political commitment, and there was commitment from the communities. So all of these things, in all of my advisors, everybody that I was working with, everybody that I talked to about this told me this was impossible. I talked to Thailand, and I said, what do you think about this plan? And they said, it looks really good, but it took us 20 years to do it in Thailand. You're never going to do this in 8 months. Everybody I talked to, oh, you can't get a vaccine from China. And just to add to the interesting pieces of this, China had just sold nuclear weapons to Pakistan, which made China and India relations not too good. And the idea that you would have a life-saving vaccine, that you would rely on China to give a life-saving vaccine to India, absolutely seemed insurmountable. This is impossible. But it all worked. And so what I want to say to you is that you're going to hear a lot of, it's impossible. You can't do that. Oh, that's not feasible. There's just no way this is going to happen. Do it anyway, because you know what? The world is constantly changing. We built off of the polio system for monitoring and evaluation that existed in UP and Bihar, and we came up with actually a very high-quality program. This wasn't something that was just done. They had coverage rates from each of the different places. They knew exactly how many kids had been covered in each area. They knew how many adverse events had happened in each of the sites, all building off of that polio infrastructure. And people weren't considering that when they were saying this is impossible. You just have to keep going forward and doing it. So the program started May 15th, 2006. Over 9 million children were vaccinated, 4 states and 11 different districts. And it was the first phase of a 5-year plan, and very high coverage was achieved. And this is the first little girl in the state of West Bengal who got the vaccine. And this is the place in 1973 where they had the huge outbreak that started the whole epidemic that went down and has been affecting India since then. So this is the vaccine. I get excited about this. Who gets excited about looking at a vaccine package? Well, I do. So here you see this. This is a Indian vaccine supply, and on here it says that it's made by the government of China. It's just awesome. I have one of these on my shelf. They're in 5-dose vials, and I'm going to show you some pictures from the campaign. So when we look at public health interventions, vaccine is one of the simplest because it's you give the vaccine and you solve the problem. 5 doses, it's a lyophilized, which means that it's freeze-dried and you have to put in the liquid and you make it liquid again. And it's a single-dose vaccine, lifetime protection. You can't have anything much easier than that. This is simple, right? This is really easy. Actually, it's incredibly complex. But it just shows that all of the different pieces that need to go into this with something that looks on the surface to be very easy. So behind the scenes, some of the things that happened. This is the day before the immunization campaign. This is in the middle of the Ministry of Health in West Bengal. They brought in all of these machines. They had to have immunization cards for these kids. So they had all of these people out there, and these are machines that are perforating these cards. They got them all printed in different colors to go to the different districts. And then they had to perforate the center so they could give one half to these kids and one half to these kids. And they had people up all night doing this and bringing these to the sites. Then there was what are they going to do with all the sharps waste? They've never dealt with this kind of sharps waste before. So we didn't solve this problem for them. They solved it themselves. They came up with a wire cutter. They put it underneath the plastic lid of this plastic container here, and they'd cut the needle off and throw the syringe away or recycle the plastic in the syringe. And then all of their medical sharps waste became this little tiny thing from these huge campaigns. Again, they had been trying to get India to look at needle cutters for years at the national level, but when it came to solving a problem at the local level, they just engineered something themselves. And one of the other things that can't be underestimated is that these are the guys that are counting out the money that they have to give each of the people to get enough petroleum to get to the different sites. And so these people are counting out 25 rupees for this person, 10 rupees for this person. We're talking cents. And lots of people, thousands of people they have to give all of this money to, keep accounting for all of this, and it's an incredible amount of work. And this is the other thing, is that they came up with a kit that they could do in case there were any adverse events. And so these were all of the pills that went in. So this is the vaccine carrier, and this is their emergency response kit with Benadryl and acetaminophen and all of these other things for the most common adverse events that happen after vaccination that they put together for all of the different sites. So the key thing is that there were results. It was extremely exciting. So this is in West Bengal. Do you see how these people are sweating? These are people who live in India all the time. It was so hot. Oh my gosh, it was so hot. Just standing around waiting. They're all waiting to get their names filled out on their immunization cards. And kids, they showed up and they finished their immunization distribution usually before 10 a.m. because people were standing in line. They were giving one shot every 2 to 3 minutes. They had a whole assembly line set up, and so that one person was getting the syringe, one was getting it filled, the other one was giving it to the child, another person finished the card, and then they just had them moving through like a conveyor belt. These are the kids after they've been vaccinated outside. And these are the happy children carrying their immunization cards, all taking that, and they were all very proud of them. So the most important thing is that this wasn't just a flash in the pan. This wasn't a single isolated piece. There was built into the plan was a point of monitoring and evaluating what happened, looking at the adverse events that happened after the immunization program, being sure that it worked, looking at immunogenicity, having post-marketing surveillance from the vaccine introduction, and using that data to make the decision to complete the 5-year commitment from Parliament for 5 years of vaccine support into all of the high-risk areas of India. So at this point, over 70 million children have been successfully vaccinated in India. And not only in India, now vaccines been introduced into Sri Lanka, Nepal, and Cambodia. And actually the picture on the front of the little program is from the introduction that happened in Cambodia this year. So, that was Mission Impossible number 1. Mission Impossible number 2. So, the neglected tropical diseases are a compilation of diseases that are very different, most of them parasitic, one of them bacterial. There's a couple of viral things thrown in there, But the most common are 7 of these diseases, and most are parasitic. Like I said, only one is bacterial, which is trachoma. And I'm not going to, I will tell you the names, but I didn't put them in a slide. Schistosomiasis, onchocerciasis, the soil-transmitted helminth, which are 3 major pathogens there, which are the intestinal worms. Did I say lymphatic filariasis? Lymphatic filariasis and trachoma. That's it. Got them 7. Okay, so these are hundreds of millions of dollars, or hundreds of millions of dollars, which are disability-adjusted life years that affect the bottom billion, the people who live on less than $1 to $2 a day. Again, these are diseases we never hear about. You don't know that they even exist. And one of the very common pieces to talk about is that we have medicines to treat animals. We pay $50 to deworm a dog for a year, and 50 cents can deworm one person against these 7 diseases, protecting them for an entire year. And it's not happening. It's because people don't even know that they exist.